database for inner retinal layer thicknesses using spectralis OCT in Indian population. So I have nil financial interest. OCT is, as you know, is a fast, non-invasive transpupillary imaging method which produces high-resolution cross-sectional images of the retina. So it is used in not just neuro-ophthalmology, also in retina and glaucoma. It produces high-resolution images. The machine which we used was Spectralis SGOCT, which was Heidelberg machine. We used the one with the auto segmentation software, and the test results had excellent repeatability and reproducibility. In our study, we actually compared the individual inner retinal layers, which are RNFL, GCL, IPL, along with the total retina. So it's the OCT uses in neuro-ophthalmology is, as we know, it's used in various conditions like papilledema, AION, compressive optic neuropathies, Alzheimer's. So we know that we follow up the patient. We analyze peripapillary RNFL, macular RNFL, and GCL in various conditions, and it is also useful in analysis of neurodegenerative diseases, and as well as it's important in glaucoma is increasing with time and more research. So we need to have a reference database for Indian patients, which I felt was really necessary we should not depend entirely on the global database. So it is not just that the foveal dip is seen in the retina, which should be analyzed in the OCT scan, but we also should look at the thickness, and we should compare it with the normal database using a color coding, which will help us know the overall health of the retina. So the aim in my study was to establish a reference database for these inner retinal layers, and the objective was to do it in normal Indian population. The population which I chose was between 18 to 87 years. I had to compare it with age. I had to compare it age-wise, sex-wise, and refraction-wise. What was the variation that could happen? The relation of the thickness and volumes to compare with the axial length, intraocular pressure, central corneal thickness, and to establish a normative database was my objectives. So this was actually an observational study which was done over a period of 1.5 years. The study population was were patients or subjects who are coming in as patients into our hospital general OPD for regular eye examination. So such studies were already done abroad. So this was my reference thesis, which was done on Caucasian population, and based on that we made a sample size of 183, and we started our study. So the first one we did it in 3 steps. First one was recruitment of patients, second one was collection of data, and third one was compilation of data. So subjects, as I told, were general OPD patients. Inclusion criteria 18 to 87 years with visual acuity between visual acuity 6.6, refraction plus or minus 5 spherical, plus or minus 3 cylindrical power. So the patient underwent normal slit lamp examination. IOP was checked to be normal fundus. We also did a HVF to rule out that the patient did not have glaucoma. Informed consent was taken from the patient. The patient excluded when the HVF was abnormal, or when the patient was found to have any neurodegenerative disease or any old ocular pathology. We excluded those patients, and patients who underwent intraocular surgery except for cataract beyond 1 year were enrolled in the study. The data collected was all the data apart from the OCT. We also did A-scan, pachymetry, and HVF. And the protocol for OCT that we used was 30 into 25 degree cube with 61 raster lines, 120 micrometer apart, meaning to say the densest scan possible in a Heidelberg OCT was taken, and the signal strength of more than 20 decibels. Only if more than 20 we selected those images, the remaining were excluded, and auto segmentation was used. Anytime when the auto segmentation failed, the patient was again excluded. So the as we know in OCT, we impose an ETDRS circle over that, which are 1, 3, and 6 mm circles in front of the retina, and we divided into central macula, nasal inner, nasal outer, and
Sorry, I think you should wind up. Can you go to conclusion?
I'll finish fast.
Wrap it up.
So results, we had the average thickness, and we had descriptive statistics where we found the average inner outer thicknesses of each layer, and it was compiled, and the correlation stats, we found the correlation, positive and negative correlations, which was compiled in in tabular column form. So in the discussion, I would like to say that our data were very similar to the previous authors who have done the similar studies, and I would like to conclude saying that a similar study with a larger sample number is definitely necessary. Thank you.
Thank you very much. Any questions? Just one question. How do you think macular thickness is important in neuro-ophthalmic conditions? Any conditions
Sir,
practically useful?
Sir, most of the patients like papilledema and optic neuritis on follow-up, we just follow up based on their vision and color vision. I would like to stress that follow-up of these patients using an RNFL and GCL thickness from the initial time will help us determine how much the effectiveness of your treatment during the acute episode. So meaning to say, if we have a very strong database, an OCT could be an investigation that you would do on a regular basis for an optic neuritis patient to say whether the amount of immunosuppressive therapy that you are giving could be adequate. And this can be, this itself will be done as a study.
Is there any difference between glaucomatous loss and neuro-ophthalmical loss?
Yes, ma'am. We find that.
What is, is there any specifics point?
So in glaucoma, we see the basically the GCL and RNFL gets affected in the specific pattern following the INST rule. But whereas in neuro-ophthalmic conditions, the loss is more generalized.
So RNFL thickness, you said positive correlation is there with age. Was it like that?
Yes, ma'am.
So how can you explain that? With age, more RNFL thickness is there as the age increases?
I didn't get your
positive
question.
Correlation means the more the age,
yes,
the more the RNFL.
Yes, ma'am.
So how can you explain that? Usually with age, the RNFL thickness should decrease, no?
But in our study, we have found that it increases with age, and it was just an observational study. So. Okay.
So one more study is there in India also, already published, I think.
Yes.
Have you seen it?
Yes, ma'am, I have seen
it. How is it different from your study?
Ma'am, so they have done GCC complex, and I have done individual RNFL thicknesses of SDOCT, ma'am. And